So, a phakic IOL is a implantation offers insertion of a biocompatible lens in front of the natural lens or natural crystalline lens of the eye to correct the refractive error. So they are available in angle supported iris fixed phakic IOLs, but we will be focusing today here on the most successful and most established and most practiced posterior chamber phakic IOL. So just to tell you that the initial were the angle supported and then the iris supported lenses were there. So first, and fortunately in 1986 the angle supported lens first generation was introduced by Baikoff. Then Buzz Freshener again in 1986 came out with the angle iris supported. This was the lens which we were using earlier, and you see there is a disinclination. One haptic has the iris. This is not inclinated; it has gone down. So these were some complication. This has happened all the 5 years. Professor Partha, please come forward. Uh, so and fortunately, 1986 Fedorov gave us this idea of posterior chamber phakic IOL, which was a collar button kind of a and made up of silicon material. It was behind the iris. So this is the basis, and this is a small video to tell you before we proceed further what is and how it takes. It takes less than 5 minutes to do a case of phakic lens. We have to be very careful. 3 millimeter incision is made, two side ports, paracentesis is made. This is the lens, and this is the ICL, no financial interest, and it is front loaded system. Um, they say to load the lens before you enter the eye, and but now for last many years I do the during on table itself over the eye. I load the lens like we do it the other lenses for the cataract surgery. The lens, the viscoelastic is placed in the anterior chamber. The lens is pushed over the surface of iris, and with the help of spatula, the haptics are tucked behind. So this is so simple, and the lens is behind the. It is cosmetically very good and very stable, and it doesn't rotate. So remove the viscoelastic, exchange it with BSS, and paracentesis wounds are hydrated. That's it. So the advantages of this is over the corneal refractive procedure is that it preserves the corneal integrity, and we can do it in KCS or suspected KCS cases. Reversibility is there, and high refractive correction. Maybe we can correct up to 1920 diopters or even more with the Indian lenses. There is reduced risk of dry eye. We don't cut the nerves, and there is an anatomical advantage because it is placed behind the iris. It is cosmetically better, far from the endothelium, close to the nodal point, and positioned in the sulcus. We can do platform toric lenses also. So these are the four companies which are available in our country. Maybe some other companies also, and Vizian ICL from Star Surgical, Care Group, Apasami, Biotech. These are the company, and you can get lenses from plus 10 to minus 18 or even minus 25, 30 diopters with Indian companies. The difference is that and in the plus variant also, and in the cylindrical correction also. So the Vizian ICL is made up of a collamer material that is different. This is more biocompatible, and the other lenses, Indian lenses, they are made up of hydrophilic lenses. So this collamer material has got 60% HEMA and only 0.2% collagen. There is a central vault. This is very important to remember. This matches with the crystalline lens rise. So our lens rise is along with this matches with the shape of the lens rise, and it is foldable. So you can implant it through a small incision, and it absorbs UV light. But the most important thing is, which has to be remembered, is the sizing issue. And this material has got collamer material. There is a layer of fibronectin which is deposited in front, so which inhibits the settlement of proteins. So it remains clear and for the long time, and that's why there is a maximum light transmission. So can we ask someone to, some of them to come forward?
What I suggest is first our apologies for not providing enough space in the hall for such an important IC. I really am apologetic from the leadership of AIOS. But please do come in and please occupy these chairs also.
These chairs you
It
can
is
occupy.
it is not necessary that chairpersons please come in, please come in, please come in, please come inside, please come in, please come in. Come in, please come in, please come in. It will give space for a few more people to stand also. Please come in. Please feel
Some of
free,
you
please.
can stand here also.
Please come. Please come. Come,
Please
come,
come
come, come,
forward.
come,
Please
come,
do
come.
not hesitate. And let others also come forward.
Come,
They are
come.
short-heighted.
Look, Purendra,
Yeah.
let's not
A
disturb
central
him.
port of
Aap idhar aa
360
jaओ.
micron in diameter is there in the new Vision V4C ICL. So this provides the free movement of aqueous from behind the lens to in front of the lens. So it eliminates the need for iridotomies and reduces risk of pupillary block and improves the anterior subcapsular cataract safety profile. So the chances of development of cataract, which is the most important apprehension amongst all of us, and for me also, it used to be there. It is now nearly zero in 5 to 7 year studies. There are multiple studies which are showing. So this is what is to be remembered. So there are two perioptic ports for redundancy. So if central port blocks, so they can provide the opening. So this design has got 5 to 6.1 millimeter optic size. So in the eye, for a 5 to 6 millimeter size optic, which is given provided to the patient, so chances of glare and halo are very less with this. And advanced version of ICL and IPCL presbyopic correcting variants are also available, and they are based on EDOF platform. And the Indian version has got some rings in it, some 4 5 rings, and Professor Tityal will be sharing about it. So what is important is that which are the cases where to implant this. In myopia correction, hyperopia up to 6 diopters, astigmatism up to 6 diopters, or hyperopia up to 10 diopters, and in cases of stable keratoconus also we can do. Post refractive surgery cases, post cross linked cases, post keratoplasty cases, post cataract surgery, residual refractive error as a piggy bank lens, pediatric anisometropia, and presbyopia. These are the off label indications. We should not do it in cases of lens opacity, any amount of cataract, do not do it. Pseudo exfoliation, coloboma lens, zonulopathy, pigment dispersion, progressive refractive errors, pre-existing corneal endothelial dysfunction, glaucoma, anterior chamber grade 2 or less, anterior chamber depth less than 2.8 millimeter, and any other ocular pathology like uveitis, iris pathology, iris atrophy, and rubiosis, anything, these cases should be avoided. It should be used as per the company from 21 to 45 years age group. Off label you can use when the refraction is stabilized. We should have a stable refraction for with no change in 1 year. In LASIK rejects, like in high myopia, when the cornea is less than 500 micron, in cases of dry eye, large pupils, excessively flat or steep cornea, these should be they are advised and advocated, and the lens should be crystal clear. Intolerance of contact lens or spectacles, this is relative, and appropriate pupil size for the specified phakic IOL. So if there is a traumatic pupillary dilatation, so in such cases, or there is congenital dilated pupil more than 6 millimeters, you should avoid, or you should explain to the patient that you may develop glare or halos. And minimum endothelial cell count should be more than or equal to 2000, or it can be matched as per the table given on the right side. And there should be adequate crystalline lens rise on ASOCT. So complete preoperative assessment, uncorrected, best corrected, dilated, refraction, manifest in cycloplegic, slit lamp examination. Important is to see the cornea, the angle, the iris, the lens. These all things should be thoroughly seen, and for the lids. And angle should be open, corneal topography and keratometry should be done, specular microscopy, fundus examination up to the periphery and myopes and all. Pupil size, scotopic and mesopic. Mesopic pupil size should be less than 6 millimeter or 5.5 millimeter. Corneal horizontal white to white distance. This is different, and AC depth. These are two different and important things which should be done pre-operatively in all these cases. And tomography and topography, many of the of the, because this course we are doing for last 10 years, so everybody asks what is the need of topography or tomography, but it is mandatory. Pentacam is an integral part. It tells us about the steep or flat K values along with axis, and it will tell us about the progressive ectasias and gives us the internal AC depth and an idea of horizontal white to white. And these are the criteria for the keratoconus or post cross-linked eyes. But there should be two or three readings where there is no progression post cross-linked or in keratoconus cases, stable keratoconus cases. Now coming to the horizontal white to white, which is the most important thing, the simple way is by measuring is by the digital calipers. They are provided by the company. They will help you to get this, and this is the most simple and most accurate and most reliable way. Other things we can do by OpScan, Pentacam, IOL Master, UBM, and some advanced autokeratometers. So this is how white to white measurement is done. It is done under the microscope in high resolution, in the supine position, in a lying down position in the OT, from middle of the limbus to the middle of limbus to the idle side on 0 and 180-degree axis. Treat the eye with anesthetic, pre-treat the eye with anesthetic drop, and we advise antibiotic drop post-operatively, and we should calibrate the caliper before using it in all the cases. There is a lot of literature is there and confusion is there. The association of sulcus to sulcus and white to white and angle to angle. But there is no clinically and statistically significant difference in vault post-operatively, which is observed when we consider white to white or sulcus to sulcus based sizing methodologies. White to white based sizing has provided the best predictability of vault till now. So this remains the most popular and best studied technique. UBM also has been studied. It tells us about the sulcus to sulcus, but there is a lack of general consensus for using this. So which, this is the most important thing which matches with the white to white measurement. So you will get a vault. What is this vault? So you can see this is the lens, anterior posterior surface of the ICL, and there is a space in between, and this is the crystalline lens. The red arrow is the crystalline lens. So this space between the crystalline lens and the posterior surface of the ICL, this is the vault. And you compare this thickness with the cornea. This is on slit lamp, anybody can see and everybody can see. So this is on the right side, you see this vault is low as compared to the left side. So this is a low vault. So this is what has to be remembered, and you have to match it with the corneal thickness. So this vault is very important, and it is due to the ideal sized ICL. So ideal vault is 0.25 to 0.75, means half of the corneal thickness. If you consider thickness of cornea to be 500 micron, half of the corneal thickness, or 1.5 times of this. If it is more than this, there are chances of development of angle closure and development of high intraocular pressure, and if it is undersized, there is an increased risk of development of the anterior subcapsular cataract, because now the lens is going to settle on the crystalline lens, and there is a chance of rotation of the toric ICL in these small sized lenses. So this is very important to be remembered and considered. So pupillometry, as we have discussed, mesopic pupil size should be between 5 to 6 millimeter, and anterior segment OCT is very important. It will tell us the crystalline lens size, anterior chamber depth, iris anatomy, and angle to angle diameter, which can be used for along with the white to white which we have measured. So this is the sheet which comes along with the lens. They give us, and this will tell us the all the things which we have, that like in this particular case, The power is minus 9 diopters, and corneal thickness is 0.506. AC depth is 3.63. So all these things you have to check it beforehand whether the patient's details are similar, and you match it, and this is the type of lens, what is the size of the lens, everything will be provided. And this has a minus 10.25 power, and the corneal thickness is 498, which is not suitable for the laser with corrected vision. So with all this, and this is the sheet which comes with the Indian lens of the similar kind, so you can match it. So to conclude, it is a safe, effective and predictable refractive correction method, better than, many studies are showing that it is better than laser vision correction, and you don't require expensive laser or anything like that. Wide correction range, myopia, hypermetropia and astigmatism. Quick procedure, it takes less 5 minutes in experienced hand. Minimally invasive, no blood, minimal pain, no hospitalization. Excellent cosmesis, reversible and does not alter corneal architecture. Minimal induction of astigmatism, preserves tear film, maintains accommodation, stable long-term outcomes with negligible regression, and improved modern designs like V4C with Centraflow is there are very less complication. I thank you for your patient hearing. We'll take up question at